All right. Hello, everyone, and welcome to season two of the Dialexicon podcast, a channel targeted to the youth where we critically engage with leading scholars and connect philosophy to contemporary social issues, all at a digestible level. My name is Rohan, and this week we are joined by Professor Tarasenko-Struc. He's an assistant professor of philosophy at Seton Hall University with a secondary appointment in the School of Health and Medical Sciences. He also holds a PhD in philosophy from Harvard University. Hi, Professor. How are you today?
Good. How are you doing?
I'm doing great. So, before we get into some of your work, I would love to know a little bit about your academic experience, how you got into the field of philosophy, any personal experiences that you thought were important in reaching where you are now.
Sure. Yeah, it's a great question. So I got into philosophy very, very early. Uh, when I was in high school, actually. When I was around 15, I started getting really interested in the religions of the world and the way they sort of included different conceptions of the nature of the world and of reality more generally. And so I'm just kind of dating myself here. This was, many years ago, but I started reading encyclopedia entries about different world religions and ideas from religion, and I was hooked. And so later on, I think actually about a few months after that, I took my first philosophy course, and this was as a junior in high school, and then I was really hooked. And so I think it was my senior year of high school when uh, a friend of mine was getting career advice from our civics teacher, and our teacher was saying you should consider being a teacher, not to me, to my friend. But it never occurred to me that the thing I really wanted to do was uh, a potential career path. And so at the age of, God, probably about 17, I knew that I wanted to be a professional philosopher. Just kind of strange, but it's true.
Yeah, that's great. And what about in your undergraduate life? How did you get into this field of medical ethics, I guess?
So the interest in medical ethics came a lot later.
Mm,
When I was an undergraduate, I mean, the joke was that I double majored in philosophy. I took all the philosophy classes that I could pretty much, consistent with, meeting the requirements to graduate. But yeah, so I took a lot of courses, and I just when I wasn't taking courses, I would just read.
mhm,
And so I knew then that I wanted to go to graduate school, do a PhD. I decided to take a gap year. So I took a year off between my BA just to sort of work a little bit, frankly, party a little bit, and just sort of experience post collegiate life, which ended up being good, except for the fact that there was a financial crisis that hit right after I graduated. So that was not so good, but it was a very fun time. And then I was told to apply quite widely. I think I applied to like 25 PhD and MA programs, and I got into some of my top choices, and I ended up choosing Harvard, and then spent about 8 years there.
Can I ask, what was your work at Harvard about, your thesis? And
It was somewhat so. My work at Harvard was quite different in some ways than a lot of my work now.
Mhm,
So I was interested in practical reason and the relationship between practical reason and the will, and the sort of more general question of how morality could be objective in the way
mhm,
that it seems to us to be. And
mhm,
that's still something I'm interested in to some extent, but basically starting my last year and continuing on from that, I've gotten interested in more practical or applied questions in ethics,
mhm,
not the sort of, super high altitude meta-ethical questions that I was interested in before.
mhm. Yeah,
Yeah.
I think that sort of divide, resonates with a lot of what I've been hearing from other people I've interviewed. So, I guess between those 2 sort of opposite spectrums of what philosophy is aiming to do, what have you found to be the most interesting? Is it what you're doing now or, um, what you previously were doing or something in between?
Something in between. I think there's still something of my earlier interests that survives in my work now.
Yeah.
Um, I've just gotten interested in a lot more and a lot
Mhm,
sort of different things. So at the end of my PhD, I started getting very interested in the nature of dehumanization, objectification, and I kind of felt like I should have pivoted my dissertation at that, but it would have been very difficult to do that at that
Mhm.
point, and so I decided to just pursue that after I defended, and
Yeah.
so that's been a red, the sort of one of the main red threads in my work
Mhm.
since then.
Got it. Okay. So this is a great transition to my next question about philosophy in general. So I have a very open-ended question of what do you think philosophy is, if you could define it or what its goal is from all of your work and in general.
Yeah, good. Um, I see philosophy as an attempt to address questions that arise when we sort of zoom out from a particular part of the world and our sort of ordinary common sense beliefs about it.
Mhm.
So I think that we sort of zoom out um, and uh, have more of the world in view or more of our beliefs in view, and we can ask questions about them. So I see philosophy as the activity of doing that, and really at being sensitive to um, questions at the very highest level of generality and
Mhm.
abstraction. So it's really like the activity that addresses the highest altitude questions that human beings could consider and think
Yeah.
about and answer. Yeah.
Yeah. So you previously mentioned your work in dehumanization now. Is there a reason or what appeal or compels you to look at dehumanization from a philosophical lens as opposed to some sort of like scientific or cognitive approach? What sort of insight does that approach necessarily offer you?
Yeah, good. It's a good question. And by the way, I am interested in sort of the psychological aspects of dehumanization as well.
Okay.
I do think, though, that uh, it's absolutely essential to understand dehumanization that we be able to sort of ask these um, higher level theoretical questions about it. So, just in reading philosophical work on dehumanization, in sort of feminist philosophy, and in sort of dehumanization studies, also in reading contributions by social psychologists, you kind of get the sense that people are talking past each other and that they really should be part of the same conversation. And so I think what philosophy allows you to do is to sort of step back and say, okay, how are people using these this similar sounding term
Sure.
in for sort of very different and incompatible ways? And more importantly, how should we be using these concepts or these terms?
Mhm.
Um, is there a way that we could refine them so that they do more work for us? Eh, what do we need these terms to do for us, or this concepts to do for us more generally?
Mhm.
Um, I think philosophy is very well positioned to address that kind of higher level question, and I think it needs to be addressed. Otherwise, we're going to keep talking past each other.
I see. And specifically on this term of dehumanization, I guess how would the cognitive scientist define it that might be different from how a philosopher like yourself might define what dehumanization means?
Um, so I think social psychologists and actually some philosophers have written on this too.
Mhm.
They tend to think of dehumanization first and foremost as an attitude or as a belief,
Mhm.
something in the head,
Yeah.
basically. And I think that's a fine way to use the term. Not gonna no major beef with that. But I do think that uh, we also use the term dehumanization and the concept in other ways. So we can, for example, describe an action as dehumanizing,
Mhm.
or a practice as dehumanizing. You could
Mhm.
say that slavery was dehumanizing, for
Mhm.
example, that the Holocaust was dehumanizing. And there, I take it we're not just saying that people had certain attitudes toward others in their head. I mean, I think it's more than that. It's that people were treated in a certain distinctively morally objectionable way. And so, what I want to know um, is moral philosophy missing something about why exactly certain actions or practices are wrong because we're using the wrong concepts. We're using the concepts of rights and duties. We're using um, the concept of well-being and harm. I mean, it's obviously like a sort of oversimplification, but are we losing something by just using those sort of more familiar concepts. And so I think my sense is that we are.
Mm.
Um, yeah.
Okay. So I guess with all of that, what do you take dehumanization to mean? How would you define it? And where does it occur, I guess?
Yeah. So I think dehumanization is an attitude sometimes. I think it could be a form of treatment too. I think at the most general level, um, it's an activity that embodies a kind of disregard for somebody's humanity, and specifically, I guess, in a lot of cases, of their characteristically human capacities. Okay, so um, when you, for example, treat somebody merely as a means to your own ends, there's a way in which uh, their their will and their capacity for experience don't really show up in the right way for you.
Hmm.
Okay, they don't play the right kind of role in your thinking, and that's why you treat them the way that you do.
Yeah,
Um, so I think that actions can be dehumanizing in that sense. I think that attitudes can be too, and I think that there's um, a kind of interplay, or in some cases feedback loop, between treating somebody in dehumanizing ways and holding dehumanizing attitudes toward them. So I think that obviously if you see somebody in a dehumanizing light, you see them just as a tool for your purposes, you're going to treat them that way. And crucially, I think you could even, if you have enough power, um, you could even make them uh, in certain ways more tool-like, or seem as if they should be used as tools, socially speaking. Um, and so I think that sort of interplay is something that I want to capture as well.
I see. So a lot of your language in describing this sort of reminded me of like, well, you said you mentioned that you did previous work in practical reason, and I'm sure you meant like Kantian practical reason, I guess, is sort of
Yeah.
allusion to that. So, and it seems like a lot of that language has been equally applicable into understanding like what does it mean to dehumanize a person. So, could you just briefly explain how, like, what constitutes a person, and then, I guess, is it about practical reason? What is exactly like human capabilities that dehumanization sort of infringes upon?
I don't know that I can briefly explain what a person is, but but I also think there's a sort of debate here. So
Okay.
I don't. I guess I'll put it this way. I'm not sure that when we talk about dehumanization, what we have in mind is um, disregard of somebody's personhood in the Kantian sense. I mean, I think that could be part of it, but I think that um, more basically what it involves is disregard for somebody's humanity.
Hmm.
So I think those two things are not exactly equivalent. But I do think that being a human being is a matter of having the kind of nature that um, brings with it certain kinds of psychological capacities. Basically, it's to have a certain kind of mind,
Mm.
not just a mind, obviously, but I think that's a sort of crucial dimension to being a human being or being a person in the sense that I care about, and in the sense that I think is denied in dehumanization.
I see. So, can we, I guess, peel back a little bit on that just to like play devil's advocate? Like, what
Yeah.
exactly is different from me from like a chimpanzee? Like what exactly happened in like the line of evolution? What is the characteristics that you think defines our humanity?
Um. Also, I think that we have a lot in common, and I don't want to deny that. Um. But I do think that unlike a chimpanzee, um, you have the capacity to um, speak the kind of language that has complex syntax,
Mm,
uh, that's that has a sort of recursive potential, so that you can embed thoughts and other thoughts. I think that human beings have a capacity for culture in a way that's richer than what animals have. I think it's fair to say that some animals have culture. Whales, for example, chimpanzees too. I mean, they seem to have certain practices that are handed down from generation to generation. So I'm happy to call that a culture too. I just think that I think that it's sort of not the same as what we mean by human culture. I also think that, and this is a really important point, that our capacities for um, choice and for experience or thought are different than those of chimpanzees. But I want to be careful because I do think that there's a tendency to sort of assume that animal capacities are very different than human capacities, and that there's not even like a version of our capacities in other animals. And so I don't want to exactly go there, but I do still think that there are important differences that matter. And that when you treat somebody in a way that denies those differences, if you treat somebody as an animal, for example, that could be a quite significant form of wrongdoing, of wronging them.
Okay. So there might not be an answer to my next question, and I just want to like sort of pick your brain on this. But have you
Yeah.
looked at like religious traditions in trying to define what humanity is? Do you think there's any sort of um, insight to be taken from Christianity or Buddhism or whatever?
Yes, certainly. I mean, I think yes. So I think that there is some insight to be gleaned from religious conceptions of humanity. I don't myself go for those, but I
Hmm.
think that we could still learn a lot from them. So, for example, I'm not Catholic, but I take the Catholic tradition very seriously. And one thing I like about Catholicism is that um, there's an emphasis on the sort of uh, centrality of being human,
Hmm.
not just being a person, not just being a rational actor, but being human specifically. So I think that's quite significant. Um, in Buddhism, for example, and again, even though I don't really go for this sort of view, I found, and this is something that I found very thrilling, especially when I was younger. I
Hmm.
find it really interesting, the idea that um, there's a sense in which what we call human beings literally have no self. um, that's super cool.
Hmm.
Again, I don't accept it myself, but I think that everybody can learn from contending with these alternative views, especially these views that might be very different than the way we're ordinarily disposed to think of what it means to be human or what it means to be a person. Absolutely.
Okay. Okay. So with that, I think I want to move to sort of the second half of your work, which is obviously in the biomedical field. So could you explain how your previous conceptions of dehumanization, et cetera, how is that applicable to the medical field, and where do you see dehumanization or paternalism occur, I guess?
Yeah, good. So maybe I'll take dehumanization first and
Yeah.
then move on to paternalism. Um, so I think that dehumanization occurs in medicine quite frequently. I mean, there are these sort of like uh well-known horrors that everybody knows about. Um, but I don't even mean that. I mean things like these more low-key or sort of less blatant forms of dehumanization or disregard. So, for example, I think it's quite common for certain people to sort of be ignored in clinical context, even when uh, they're being seen by a provider about their own care.
Yeah.
So I'm thinking in particular of disabled people, elderly people, where they're not even treated as partners in the conversation about their care, even though they have, let's say, full competence or decisional capacity. So that sort of thing. Um, but I think that it shows up in other ways too. And I think that even when some of our practices in medicine are permissible or in principle permissible, there's still a kind of still something dehumanizing about them. So let me give you an example. Slow coding. There's a very common practice of um, basically caring for a dying patient
Mm.
uh, for whom there really is no hope. I mean, this person is actively dying, let's say. Um, no amount of aggressive treatment will bring them back to life or make them fully healthy again. Okay. In those situations, families do different things, but a lot of one thing that a lot of families do is they'll say they want everything done, and this creates a moral dilemma for providers because the providers, you know, it's they're the ones treating the patient, and they find it sort of horrific to put somebody through, for example, CPR when there's no realistic chance that the person will be revived, or if they are revived, there's no realistic chance that they'll attain a decent quality of life. Okay, so in those situations, they pursue a slow code, what's called a slow code, where you give somebody goes into cardiac arrest, for example, um, you give them CPR, but you do it in kind of a fake way, right? So you might do chest compressions less vigorously. You might not spend as much time. Uh, the joke that I heard from some of my resident friends was, you know, code blue will be called, and then they'll say, "Oh no," and then like walk really slowly. I mean, this is the sort of thing that happens. Walk really slowly over to the hospital bed to revive the person. So anyway, I think that this has tremendous potential to be deceptive, to be harmful in certain ways, and I want to acknowledge that up front. I think it often functions as a way of basically evading tough conversations with families. Uh, But I think that in some cases it could be permissible, basically. Um, and so I've offered a very, very limited defense of the slow code where I basically say this has dehumanizing potential, and in particular, it amounts to, or it can amount to, um, treating the patient's body as a tool for another's purposes, to basically um, to pacify or bring solace to their family. But I think in some cases it could be okay, morally permissible to pursue a slow code. Okay. Um, so that's one example. Um, but beyond that, I do think that we need the notion of dehumanization to make sense of certain other more sort of infamous wrongful practices, like the practice of forced or non-consensual sterilization in the U.S.
Mhm.
And other countries too, of course, but like I'm focused on the U.S. context in particular. So I think that there's a lot of things we could say about why sterilizing people without their consent, especially uh, cognitively disabled or black or indigenous people, there's a lot of things we could say about why that's wrong. Um, but I think that talking about violations of autonomy or harm doesn't quite get at one of the core wrongs of this sort of practice, which is that uh, it amounts to treating those people as animals, right? Like pets. We sterilize dogs and cats, or I mean, we don't always, but like there are good reasons to do that. It seems appropriate in a way that it's not appropriate to sterilize a human being without their consent, at least where they're capable of giving consent. Um, so anyway, that's just another example. Uh, about paternalism, it was actually some of my work on animalization that got me interested in the ethics of paternalism. Because I do think that going back to the sterilization example, you can sterilize an animal in some cases for the animal's own good. Um, you can, for example, give your dog a hysterectomy if she has a tumor on her ovaries or something. And that seems appropriate. But I think that kind of radical paternalism is out of place with human beings, at least ordinarily. And so got me interested in um, just when exactly paternalism is toward sort of,
Yeah.
let's say, competent human beings, adult human beings, might be justified. Another thing that got me interested in that topic, though, was working as a clinical ethics consultant at Albany Medical Center, which is where I did my clinical ethics fellowship. And so I realized that on the one hand, people seem to acknowledge that competent adults have a right to refuse medical treatment, even when it's necessary for saving their lives, and even for bad reasons,
Yeah.
or reasons that other people would see as bad or just wouldn't understand. So that's on the one hand. On the other hand, it's very, very common for people to receive medical treatment over their refusal, and not just in connection with sort of eugenic programs of sterilization, but I'm talking about the emergency department of your hospital,
Hmm.
uh, the locked psych unit in your hospital, the maternity ward, just all these settings are sites of non-consensual or forced treatment, or can be, or historically have been, and not in recent history. And so I found that jarring. Just at the very least, it made me wonder why, because it kind of smells like a double standard, right?
Hmm.
Somebody who is young can refuse blood products because they're a Jehovah's Witness and have their refusal honored by their care team, and the person who is suicidal and really wants to die, and wants to die for what seem like decent reasons, um, is still treated over their objection. They're locked in a psych unit. They're put on a safety sit where people, physically restrain them if they try to harm themselves. And so, at the very least, I think that raised the question of why we do things differently in those other spaces, and whether what we're actually doing is in line with people's rights.
Okay. I guess I would want to bring up the question of like maybe children or people that might not necessarily have what we deem like fully functioning decision making capabilities, whether that be they have some neurological disorder or something
Yeah,
along those lines. How does your theory um, account for those instances? I guess.
yeah. So I think children are a tougher case, or that they can be. Um, I think there are really hard questions about the ethics of forcing treatment on mature minors, for example, people who are like 15, 16. They're not babies, they're not toddlers. Their capacities look pretty similar to those of adults, maybe even sort of better than those of adults for some adults. So I don't, I do want to work on that question, but I haven't gotten to that yet.
Mm.
But I am interested in whether it's permissible to force treatment on people who have certain psychiatric disorders. Um, People who, for example, are suicidal, or people who have anorexia nervosa, people who struggle with addiction. We do often treat them over their refusal, right? We stop the suicidal person and maybe medicate them against their will. We force feed anorexic patients who are on the verge of starvation. Um, in I think, quite a few states in the U.S. I think the number is 27. You can uh, get a loved one who is struggling with addiction in a really serious way. You can get them detained, uh, which I hadn't heard about before I started working on this topic, but it's pretty wild to me. Um, and in any case, so I think that in some cases, doing all that I just mentioned might be permissible. I think in some cases, yes, we should stop people who are depressed from ending their lives. We should force feed anorexic patients in some cases, or forcibly treat people with addictions maybe. But at the very least, it's not obvious why we get to do that. So in some cases, I think we could say you just don't have decisional capacity. Okay, you lack one of the sort of four standard abilities that are normally associated with decisional capacity, and that we think give people the right to make their own medical decisions. I think in some cases we can say that with respect to all the cases I just mentioned, with all the conditions I just mentioned. I think in other cases that's not true, um, or at least it's not obvious. And so the question there becomes, is it that our conception of decisional capacity is just too relaxed? If we're counting suicidal people, anorexic people, and people struggling with addiction as having decisional capacity, that's a possibility. Maybe it's just the concept is not in proper shape
Mm.
to get the right results here. Another possibility, though, is that these people have capacity, and there's still really good reasons to give them medical treatment over their refusal. So I think that's a possibility. I will just say that it's at least a somewhat jarring possibility, given that um, again, we usually think that people have a strong right to refuse medical treatments, as long as they have decisional capacity with respect to that choice. And so there's a question of what makes anorexic patients, suicidal patients, addicted patients different.
Yeah.
Or maybe it's the case that we should just be much more paternalistic toward people, for example, toward the Jehovah's Witness or the patient with terminal cancer who just doesn't want to go through with chemotherapy for a chance at a few years of extra life. Maybe we should be more paternalistic toward those folks as well. That's another possibility, I think.
Mm.
But it's at least a, a counterintuitive possibility, I'll just
Yeah.
say.
Yeah, for sure.
Yeah.
And I mean, like, it's obviously a very difficult question, but is there any answer that you think you've reached about why these cases might be different or how we're able to do this? Like, uh, yeah, like, is there any sort of solution that you see in mind or what a solution would have to look like? Just something along those lines.
So I think so. As I mentioned, I think we could still say that it's permissible to force treatment on some people who fit into these categories. For example, some people who are suicidal are depressed,
Mhm.
and there's good reason to think that depression does compromise capacity, or that
Mm.
it can in a lot of cases. Okay. Um, and I think the same could be said for anorexia. I mean, certainly anorexia nervosa, which is much more, in certain ways, much more complicated, and probably addiction too. What I'm less sure about is whether there is an ironclad justification for forcing beneficial, essentially life-saving treatments on people who, by all accounts, count as having capacity. That that I'm that I'm much less sure about. And I think that to answer that question, we're going to have to ask really tough questions about um, whether paternalism is justifiable. Why is it so important that people uh, be allowed to live their lives and maybe end their
Yeah.
lives by the light of their own values, um, when by doing that, they could be making themselves much, much worse off. I mean, they could be cutting their lives short by decades in some cases. It's at least not obvious that respect for autonomy is that important that it totally overshadows considerations of beneficence or the patient's well-being. And so I think that, I mean, I would like to see some of these debates move toward a more careful consideration of when exactly we get to and why exactly we get to interfere with people's freedom for their own good and without their consent.
Okay. I think you briefly mentioned something about like four criteria for decision making capability or something along those lines. Is that so? I've never heard of that. So could you talk about what?
Yes. And actually, I mean, I'm talking about the just the sort of standard notion of decisional capacity that has a lot of currency in bioethics and in clinical settings more generally. Um, so the idea is this: to count as having decisional authority, the authority to make your own medical decisions. Um, you need to have, and it's enough to have, four abilities: the ability to communicate a choice, where that has to be a stable choice in some sense. Um, the ability to understand general information about your condition, for example, about uh, the nature of the treatment that's being proposed to you, or your different sort of treatment options,
Mhm.
including no treatment. Crucially, and this is the third ability, the ability to not just sort of understand in general facts about some medical condition that you have, but to have insight into the fact that you have, sort of bring that general information home to yourself. Um, and that matters because some people might very well understand all these uh, important facts about, for example, the nature of breast cancer, but they still deny up and down that they have breast cancer, even though they've been told by multiple physicians that they do, because they're in the grip of a delusion. So that person would count as lacking decisional capacity. And then finally, the fourth ability is reasoning. So basically the ability to make inferences um, from this sort of the general facts you're told, um, uh, especially inferences that pertain to the effect of different treatment options on you and things that you care about. So that's a sort of standard view. It's actually quite new, and it's actually quite controversial. It turns out that there are debates about whether these criteria are just too minimal. 'Cause, I mean, it's pretty easy to tick those four boxes. um, and so there's a question of whether those four boxes are enough, or whether you need to add more boxes or just something else. Whether you need to sort of a new model of decisional capacity. That's something I'm also quite interested in.
So what what are like your views, I guess, on your this like a revision to this criteria? Do you have any suggestions or
I don't. I wrote a paper on the ethics of force feeding anorexic patients, and in that paper I went through different possible revisions to the standard four abilities model, and I'm very open to, at least in the abstract, to revising the standard view. I think it probably should be revised. I'm not sure how to do it, and actually in that paper I ended up convincing myself that I was dissatisfied with all the revisions that have been proposed, for various reasons, which I'd be happy to talk about. But basically, I think that they all get uh, quite counterintuitive results, and they end up sort of expanding uh, the scope of permissible paternalism in ways that I cannot accept, and that I think we probably shouldn't accept. They basically too many people end up lacking capacity, and therefore being candidates for forced treatments if these proposed revisions
Mm.
are true. And so I think that for that reason alone, I think they can't be. So
Okay,
anyway, TBD, but I'm sensitive to the need for a different view. I'm just not quite sure how to do it yet.
I see. But just to, I guess, give more context, do you have any like uh revisions that you remember that you can sort of explain your objections to just to get it for yourself?
Yeah, good. So one one sort of influential idea for how to revise a standard model is this. In addition to the four abilities, to count as having capacity, you need to not be acting on the basis of what are called pathological values. So in that sense, your choice has to be authentic, meaning specifically that uh, it cannot be the case that you're acting on values that you have because you have a clinical condition.
Mm.
Um, they have to sort of, so to speak, your decisions have to flow directly from you, not from your anorexia nervosa or your depression or whatever else. So there's something intuitive about that idea, but I think that it figuring out exactly how to distinguish between a person, decisions that come from a person's true self on the one hand, and decisions that just come from the person's pathology or disorder. I think it's incredibly hard to do.
Yeah.
Not least because and this is kind of disturbing, but I think in some cases, um, there isn't much of a separation. So I'm thinking of somebody who has had um, a psychiatric disorder for years, since adolescence or childhood. In that case, I think it's really hard to separate their authentic self from their condition.
Mm.
Okay. Um, I also think that psychiatric disorders, even when you recover from them, psychiatric disorders can uh, put you in touch with valuable things that you otherwise wouldn't have had access to. So, an example that I use in the paper is this. Suppose I have OCD, obsessive compulsive disorder. Um, it might be that even though I've gotten to a point where it doesn't really dominate my life anymore, because I've had OCD and I've had that experience, I really have come to appreciate the value of being really clean, and things being really orderly. If not for my OCD or my prior OCD, I would not have grasped that value. But it sounds weird to say that that value is pathological just because it's based in a pathology, and I wouldn't have had it had I not had a
Mm.
disorder. Um, so anyway, that's I, for that
Yeah.
reason and other reasons. I'm actually quite skeptical of this idea, or at least as a way of revising the standard model of decisional
Mm.
capacity.
Okay. So we spent some time on this tangent, but I want to go back a little bit to
Yeah,
some of your main work. So you mentioned you worked at the Albany Medical Hospital. I think that was um, right. So could you talk a little bit more about what was your experience there? Like, did you, like, I guess, what was your role, and did you have like direct contact with medical professionals? Sort of, what was your work and influence in that role?
yeah. So the fellowship was a little bit of a hodgepodge in that I did research, I taught in the uh, in the medical school and in the professional studies graduate program, and then I trained to do clinical ethics consultation, uh, meaning that uh, I would get calls from, I mean, usually it'd be doctors, nurses, social workers, sometimes from patients' loved ones, and they would have tricky ethical questions that they wanted my advice on. And so I was expected to, yeah, to sort of to follow up, to get all the information that I needed from different providers, for example, or social workers, and to talk to the patients in a lot of cases, or to their families in some cases, and then to give a recommendation, and to not only just say like, do this, don't do this, but more importantly, to sort of uh, give a set of reasons for the recommendation.
Sure.
Um, and so I think I probably, oh God, I don't know. I probably consulted on almost 100 cases. That sounds right. Not quite 100, but it was in that general region. Yeah. Some of them were boring. I'll be honest. Some of them were very boring, not much ethical content. I mean, no, seriously, like some of them were, I don't know, like this patient is incapacitated, they have a wife, and they have a girlfriend or a domestic partner who should make decisions for the patient. Like, so like that's I don't know. That's like sort of socially interesting, or
Yeah.
something, but or like from like a reality TV perspective. But ethically, it's I think less interesting. But then these other cases that really just like floored me.
Mm.
Cases where, for example, you know, uh, like a homeless woman uh, was pregnant, and there was a concern that she would uh, experience a hemorrhage during labor, or maybe
Mm.
before, and she was sort of known for kind of randomly refusing treatment. And so the question was, what should we do if that
Yeah.
happens while she's delivering? Like, and
Yeah.
she experiences a hemorrhage that threatens her life and her baby's life. So cases like that, I
Mm.
mean, really put pressure on your ethical thinking, and I think at that point, ethical ethics is not just theoretical.
Yeah,
um,
for sure.
I mean, it has real stakes, real human
Definitely.
stakes.
Yeah. Yeah, definitely. I think you mentioned also that you taught at their medical program. So I'm interested to know, like, what were sort of the core values, or what were you, like, trying to instill within the students, I guess? Well, what did you find to be the most important for them?
Um, yeah, so I had very different experiences teaching at the medical school versus in the graduate program. So in the medical school, it was in some ways very casual. Like I basically ran a discussion section.
Okay.
So students would uh, they would go to lectures, or I
Mhm.
guess it was video lectures. They would watch lectures, and they had assignments, and then we would discuss it. So that was nice. I mean, that was kind of
Yeah.
more like grad school for me.
Yeah.
But they were smart. I mean, they're motivated. You never had any sort of issues that you have with, or that you can't have anyway with sort of younger undergraduates. So that was nice. It was like a section of really good students,
Mm.
and they were quite open um, to discussing at length and these like very complex ethical issues that they would have to. I mean, in part because they would have to face them in their future practice.
Yeah.
Uh, and they weren't as I don't know, they weren't as uh, sort of deep in uh, the tangles of clinical practice. So they were more able to take a more critical eye towards certain aspects of, what they were doing or what they would be doing. Um, but as far as core values, I think that more than anything, with the medical students anyway, I wanted them to be able to express their actual views and to debate their actual views. And so I don't think I ever imposed my own views on them. I might have told a few of them what I thought about certain issues, but that was really the extent of it. Um, and I think they appreciated that neutrality because actually it meant we could have a debate instead of what they were used to, do, which was just like we get asked questions and then maybe somebody says the right answer, maybe not.
Yeah.
And in any case, the instructor says the right answer eventually. So I think that's what they were used to in other cases.
I see. And, like, what were, some of the like, what was the range of students' responses to, like, incorporating, like, ethical issues to, like, their normal sort of scientific studies? Like, um, did they really grapple with it, or was it sort of just like a course? Like, I'm interested to know, like, I guess, broadly your views on ethical education, like philosophy education in other fields, like medicine, for example.
Yeah. Um, oh yeah, I mean, I'm hugely in favor of it. Uh, and actually that's why I uh, take my teaching responsibilities at Seton Hall very seriously.
Mm.
Uh, I think that, I mean, honestly, nothing worries me more. I mean, maybe not nothing. Few things worry me more than being the patient of a doctor who doesn't think about
Yeah.
the ethical valence of what they're doing ever. Not because they think they've figured out the right answers, but
Yeah.
because they just don't care. I mean that's really terrifying to me. And you meet people like that, frankly, sometimes. But so yeah, I'm a huge proponent of uh, embedding ethics education in medical school curricula and before that, actually. 'Cause, I mean, I think that there's a way in which it's not ideal to start ethics education in med school. You really should start at the undergraduate level and
Mm.
before that even. Uh, and so that's something that I take very seriously about my job.
Yeah.
Mm.
Totally
Yeah.
agree. And that's why doing this podcast is definitely
Yeah, good. Good for you. That's great.
all right. And so my last sort of topic is actually very tied to this. So it's just about the youth and education in philosophy in general, but maybe not even in university, but in high school and even younger than that. So,
Yeah.
looking back, do you think you have any advice for young people interested in bioethics or in philosophy in general, and, like, how they should go about approaching the field?
Yeah, good. Um, So what I would say is this. So I think the most important thing is to read.
Mm,
I think so, and I think that don't just read. Obviously, I'm not saying just read. I think you also need to talk to people. I think it's great to watch podcasts like this. So if you're watching, good for you. But 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 I do think it starts with reading. Uh, don't just read stuff you're assigned. Read stuff you're interested in. There's a lot of interesting philosophy out there. I think so. I think you can read the classics, and I would recommend it definitely. So you have uh, a sense of context for some of the more contemporary debates you might be interested in. But there's just a lot of interesting philosophical work out there. Um, there is, uh, for example, I mean, there's work on like how to understand FOMO, fear of missing out. There's work on uh, reincarnation. I mean, there's just like so much fascinating contemporary work out there. So I think first and foremost, I would say read. Always be reading. But again, I don't think that's enough. I do think that you need to find other people who are interested in this stuff to talk to. Um, and so I think finding a community, and ideally a sort of in-person community, friends maybe, is another important step in the process. Um, the other thing I was going to say is, uh, like when I was young, this is when I was working sort of I don't know, bullshit jobs, like in my gap year, like I was always listening to stuff. I didn't really do podcasts, but like I watched YouTube videos of lectures, of talks. That's something that I found. I just had them on in the background sometimes when I was doing other stuff, like sort of office work. I think that's really crucial too. I think that like there's a way in which you have to immerse yourself in philosophy or in sort of particular things you're interested in within philosophy, and to do that with other people. So I think those are sort of the most important things I would recommend. And then finally, um, if you find authors whose work you're interested in who are alive, and some people are dead, obviously. Don't bother about them. But a lot of us are alive, like me. uh, like if you're interested in their work, talk to them about it. I mean, sometimes they don't have the time, um, but like other times they will engage you. Like I'll engage you, and they'll send you work that you might not have access to otherwise. Okay, and so I think that's the last thing I would say. Like, just remember that philosophy is not just like stuff written by a bunch of dead people long ago. It's like I mean, it's partly that, but it's also stuff written by people who are alive here and now and whom you can have a conversation with.
sure.
That's what I would say.
Okay, great. Thank you. I think that was really helpful for both myself and a lot of our viewers, because it's a very daunting field, I would say, just to get into, and just the name of it, obviously evokes sort of association with Europeans in the 15th century or whatever.
Yeah.
Anyways, okay, so I won't take up much more of your time. I think we can wrap up the episode here. So thank you, Professor, for your insight and obviously your time for an hour. I definitely learned a lot, and I'm sure our audience did as well.
Really great talking to you. And again, I think it's really great what you're doing. Keep doing it.
Great. Thank you.